If you have joined us today, welcome to the Australian Institute of Health Innovation at Macquarie University's webinar series. I'm Associate Professor Rebecca Mitchell and I lead the Health and Societal Outcomes stream here at the Institute. Today we'll be talking about inequalities in dementia care, and I'd like to introduce to you the two speakers that we have today from the University of Liverpool. But firstly, with more than 10 million new cases of dementia worldwide each year, inequality in dementia care is a really pressing global health issue. I know in my own research, we've been exploring hip fracture care for older adults and access to rehabilitation for adults with living with dementia. And we've been finding that these adults living with dementia were 6 times less likely to access in-hospital rehabilitation after a hip fracture than adults with no dementia. So there are certainly some inequalities around in Australia. But today we have Dr. Clarissa Giebel and Professor Mark Gabbay from the University of Liverpool with us. And Clarissa is a Senior Research Fellow at the University of Liverpool and a National Institute for Health Care Research applied research collaboration from the Northwest Coast, leading research into inequalities in dementia care and ageing. And she works with international collaborators to address barriers to accessing and using dementia care. And Clarissa will be discussing her latest research into many inequalities in dementia care from a UK and international perspective. And we also have Professor Mark Gabbay, who is Professor of General Practice at the University of Liverpool, where he is also Head of Research with the Department of Primary Care and Mental Health, and he's the Director of the National Institute for Health Care Research, Applied Research Collaboration in the Northwest Coast. And Mark will draw on his experience as a Director of the National Institute for Health and Care Research, Applied Research Collaboration, and as a GP to discuss how health systems can better be embedded in public health, public involvement and co-production in dementia care in order to improve equality. But before we get started today, I'd just like to acknowledge do an acknowledgement of country. And I'd like to acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wellcome people of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We acknowledge the traditional custodians of the various lands on which everyone has joined today, and the Aboriginal and Torres Strait Islander people participating in this webinar today. And we certainly pay our respects to elders past, present and emerging. Just a little reminder, at the Australian Institute of Health Innovation, this is our goal, is to create high impact health services and systems research that drives positive change in policy, practice and behaviour for the benefit of all. And we have 4 leading research centres here at our institute, led by Professor Jeffrey Braithwaite as our founding director. We have the Centre for Healthcare Resilience and Implementation Science, with Joanna Westbrook leading the Centre for Health Systems and Safety Research, and Enrica Carrera leading the Centre for Health Informatics, and Henry Cutler leading the Macquarie University Centre for Health Economy. So now back to the start, and I'd just like to now hand over to Clarissa to take us through her presentation. Thanks, Clarissa.
Thank you very much for the invitation, Rebecca and Chrissy. So whilst I'm just sharing my screen, which hopefully will work, just bear with me a second, please. Here we go. All right, just thumbs up maybe if you can see this, or just, yeah, lovely. So I'm going to go on big screen share. And here we go. So again, thank you very much, Rebecca and Chrissy, for inviting me. I'm Clarissa Giebel. I'm a senior research fellow at University of Liverpool. So I am with a Wellcome Trust funding. I am here in Australia for a few weeks, specifically working with Professor Brian Draper, and he's connected me with lots of really interesting aging and dementia researchers. So this is how this opportunity came about. And today I'd like to give you a little bit of an insight into our research into inequalities and dementia care. It's just an insight. We're doing much more, but I thought let's pick out those couple of projects that we've been working on recently. And really, it's all about trying to see what are the barriers in accessing dementia care and how can we overcome them, because really that's the focus of my research agenda. So, talking about inequalities, we know that there's a lot of barriers to accessing a dementia diagnosis in the first place, but really our research looks primarily at what happens once a diagnosis is made, or what happens if someone doesn't get a diagnosis but still needs access to care services, which happens a lot, for example, in lower and middle income countries. So looking at post-diagnostic support specifically, we're interested in how people are accessing support groups, peer support groups in the community, how they're accessing daycare centres, respite care, residential long-term care, etc. But also how paid home carers can come into your home, for example. So what are some of the barriers that people experience? Now, there's many different barriers that are experienced by people with dementia and their unpaid carers. It's about their ethnic background, for example, where they live. Do they live in more rural areas or more urban areas? Their gender can contribute to this as well. Do they have sufficient funds and financial means to access services? Do they have the knowledge and awareness about it? So it's not just about their general educational background, but also that health literacy and being able to navigate the healthcare system in terms of, I know where to access care. And for us in England or the UK as well, navigating the social care system. So once someone has received a diagnosis by a memory clinic, usually in England and the UK, what happens then? So unfortunately, many people living with dementia who receive a diagnosis are often dropped effectively. Once they have a diagnosis, they receive very little support and they have very little support to navigate that system. So throughout our research, we've come to kind of look more at different levels of inequalities and different levels of barriers that people might experience, including more system level approaches, community level approaches, and individual level barriers as well. So I was talking quite a bit about individual level barriers just now, but there's also community level barriers. And we noticed that particularly with our research in, for example, Colombia, and India and Uganda, so more low and middle income countries where there's generally a lower level of awareness of dementia and mental health in general, but also a lot of stigma. So if there's so much stigma out there and very little resources available to support people with dementia, then it might be more difficult for people to access care in the first place as well. And looking at system levels as well. So it's about what funding is available, are there needs assessments, for example, but I'll go into this in more detail, but it's just to kind of start off this talk by breaking it down on those different levels of barriers. Oh, and also I was reminded to remind you, the audience, throughout, please drop your questions in the Q&A because we'll pick them up afterwards, okay? So if at any point during my talk or during Mark's follow-on talk, there's any questions, please just drop them in the Q&A. So today I'm going to share with you two particular studies where we have looked at inequalities in dementia. The first one is looking at COVID-19 and its impact on inequalities, looking at UK data that we collected in the first few months of the pandemic. The second study is a two-country comparison on inequalities, which was affected by the pandemic and we had to cease recruitment. So that's between the UK and the Netherlands. So first of all, I'm going to talk about the COVID-19 study. So what have we done? We've done a quite large mixed methods approach. We've done a national survey and a baseline and follow-up interview study. We collected data between April and August 2020. So to put the pandemic into context and what's been happening in the UK, we had a national lockdown in late March, as I'm sure it was across the world around that time. But since then, it was basically everything was shut down. And the reason why we started this particular project as well was that in all of our research, we work a lot with people living with dementia, unpaid carers, health and social care providers, and charity organizations as research members. So it's not just academics, but it's everyone with those really important lived and professional experiences that are part of the team. They help us analyze data, design documents, the questions for interviews, etc., generate the dissemination strategy. So a lot of our research suddenly, or at least the recruitment suddenly ceased because of the pandemic and everything was face-to-face. And I've had lots of carers who are part of our project teams come up to me, obviously virtually, via WhatsApp or emails, etc., or telephone, and said, I can't get any access to support for my husband anymore. I can't get any support for my mum with dementia anymore. I struggle to access anything. And they've already stopped doing that before the official lockdown, late March. So we were fortunate to secure some funding very quickly to try and understand how the pandemic has impacted social care and social support for dementia. So as I was saying on the first slide, when we look at social care, social support, it's all these things that people can access in terms of peer support groups, daycare, respite care, but also institutional long-term care. So the survey and the interviews were both designed with a large group of unpaid carers, one person living with dementia, lots of charity organizations, clinicians, social care providers. The survey was specifically looking at the access to different services and how that access was facilitated before the pandemic, so within the last 6 weeks or so before the pandemic, and then since. And we've had 3 time points, one in April, May, one in June, July, and one in August. And you see here how many people participated at those survey time points. We also asked people, obviously, socio-demographic questions, but also about their levels of depression, anxiety, well-being, so established questionnaires. To complement this quantitative data, we also conducted quite a large amount of follow-up interviews. So we had 50 baseline interviews in April, a majority of those with carers and people living with dementia via Zoom or telephone. And then a few months later, in June, July, we conducted 20 follow-up interviews. So what I'm going to do now is I'm going to give you a snapshot of the findings, specifically looking at experienced inequalities. So first, looking at the survey data, looking at service usage by time and time point. Now, we did ask participants for more than those types of services, but the reason why we selected those to be presented here and in our paper as well, if you want to read about them, is that those services were the most frequently utilized, at least prior to the pandemic. And what you can see here, so for each of those 5 services, you have pre-pandemic, the light gray bar, and the percentage on the left is just indicating the percentage of the sample size who access those services. And then you see here time point 1, 2, and 3, how this has changed. And I suppose one of the first key findings is how much it dropped. It dropped significantly, the usage, just because of face-to-face restrictions. But thinking back now, where we're at now, about 2.5 years or even more later, it's really important to have that data because we also found that the reductions in social care access were linked negatively to mental health and well-being in dementia and the unpaid carers. So we need that data on record and on evidence to make really informed decisions when a pandemic happens again. So you see here it's dropped significantly. What you can also see is that the paid carers access seemed to stay relatively stable and actually increased again. Now I'll go into this in a couple of slides down because we generated very interesting qualitative data to contextualize these findings. Another thing that you can see on this here is that for support groups, daycare, befrienders, and social activities, they stayed pretty much the same, just because social activities, etc., they were keeping on being restricted face-to-face, so everything was just done remotely. Except support groups, we see a slight increase again, but we know from our interviews that support groups started to adapt slowly to being done remotely via Zoom, just as like we're doing now. So this is kind of, I hope, painting the picture in terms of the quantitative data and getting an understanding of the numbers behind the service usage. So what about the qualitative findings? One thing to point out here now that's not linked to inequalities, but it paints a really important picture, a background picture, is that we noticed in our interviews in April 2020, so that's only up to about 5-6 weeks of national lockdown, that people seem to be deteriorating faster. So we know that all those social support services, social care services were closed down. People were restricted to their own home. They weren't supposed to go out except for once a day for a walk, etc., or if they had to get groceries, etc., for really necessary things. So the caregivers were noticing this really increased levels of deterioration in their relative with dementia. Now, that can be obviously from the increased social isolation, reductions in cognitive stimulation, physical stimulation, etc. It could also be because carers were suddenly asked to do even more of those caring duties. They were faced with even more caring hours, effectively, of seeing their relative with dementia, whereas before, the person might go into a daycare center or respite care, support groups, but now suddenly they're witnessing this much more. So there can be a number of factors, but we have noticed this, and in a systematic review we've done since, a global one, looking at evidence from 15 countries, we found similar findings. Okay, so they've been replicated since. Now, I was mentioning 2 slides earlier about the findings on paid carers and how paid care access seemed to be going up again after the first drop. Now, we collected a lot of qualitative data where carers were talking about accessing paid home care and the really difficult decisions they were facing. And here you have a particular quote, but just to kind of say, in general, we found that many carers were really fearful of different caregivers coming into the home, potentially bringing in the virus and obviously infecting the relative with dementia who was already vulnerable. So many carers decided, no, I don't want to receive any more outside support. Instead, I'm taking on those caring duties, which in return led to increased levels of carer burden. Other carers, unpaid carers, were thinking, I just can't cope. I can't deliver all these caring duties myself. I need to have that carer from the outside coming in. So really, people were in different camps about this. And it's all about how the carer and the person with dementia was feeling. But to put it into context of the UK social care workforce, and I'm not too sure how it is in Australia, I'd be really keen to hear, is that in the UK, it is not uncommon that a person with dementia or an older adult with very high support needs might have up to 10 different paid carers coming into the home a week. So now picture that, sorry, just slight distraction. Now picture that 10 different paid carers come into the home, potentially bringing in the virus, and unpaid carers don't really know much about where they have been, have they adhered to infection control measures, etc. So this quote here is one example of a caregiver who's faced really difficult decisions in terms of whether she will continue to get financial support from the local authority. So in England, it's often based on needs assessment. So if someone is from a more financially disadvantaged background and needs a bit more financial support to care, then they can receive care if they're judged at a certain level to be eligible for this. Now, this particular carer said, I really don't want anyone to come in to the home. sorry, just a second. I'm getting really distracted. Sorry, it's really distracting right now. So this particular carer was saying, I really do not want a paid carer to come into the home, but sorry, can we it's just hang on just a second, sorry about this. Sorry, back in. There are two presenters in the room, which could be a little bit distracting, but I'm on it now. So she didn't want to have the paid carers come into the home because she was fearful of the virus. So she said, however, if I drop the financial support from the local authority or council now, I'm really worried that I won't get that financial support again after the pandemic, when I really want to have carers come in again. So because of her financial and economic situation, she was placed in even more difficult situation as a caregiver, just as an illustration of the inequalities experienced. Obviously, there's been many inequalities before the pandemic, as we've discussed with our carers as well, and as we've heard from many carers and people living with dementia who took part. And even prior to the pandemic, many services in the UK are not necessarily suitable or not accessible to people living with dementia or their carers. So that includes anything from people living with young onset dementia, services aren't really catering for this, people from different ethnic minority backgrounds, for example, from a South Asian background or Chinese background, services aren't catered to the linguistic support. But also if someone has, for example, more of a subtype of dementia, such as Lewy body dementia or vascular dementia, Parkinson's disease dementia, all different features, and people might not feel adequately supported in a group that's only for Alzheimer's disease dementia or for older adults living with dementia. But then since the pandemic as well, it's all about accessing care remotely, accessing care via the internet. And we've had a lot of quotes when reading through our transcripts together with our public advisors, etc., saying that it was so difficult accessing, for example, support groups via Zoom chat, like we're doing now, because many people in the more advanced stages or with vision deficits as part of their dementia, such as PCA, for example, they might really struggle understanding, picturing those little Zoom boxes and visualizing, oh, this is Mary from the support group, I usually sit next to her, etc. So again, it didn't bring the same benefit to people accessing things remotely, but also just navigating the maze of the care. So we've had the word, the maze, featured a lot in our interviews in pre-pandemic research, but also particularly in this study. It's just, at least in the UK, it's incredibly difficult to find out what's actually available for me once I have a diagnosis or once my loved one has a diagnosis, because what tends to happen a lot, not all the time, but a lot, is that once someone receives a diagnosis from the memory clinic and then is being passed back on to their GP, so general practitioner, their doctor, that there's not much to follow up. There's no single point of contact. And what we've evidenced is that it's usually down to unpaid carers who are quite savvy in terms of looking digitally or looking in their local communities for support groups. People need to be proactive to find that care. But let's now imagine that there's an older person living with dementia without an unpaid carer. They're even more disadvantaged in accessing the support they need. And we also had some novel inequalities. I don't know how it was in Australia, but at least in the UK, we've witnessed that people living with dementia were not classed as vulnerable during the pandemic, which meant that they were unable to access priority shopping slots. So they were reliant on having an unpaid carer to getting that basic need of getting food delivered to the house. There were also many difficulties in accessing AGP or general healthcare services since the pandemic. And as I was just illustrating again as well, the digital component, everything happened remotely, which was really difficult for many people. And they had to have that support from an unpaid carer unless they were already digitally literate and could access support remotely. So what now? Obviously, the pandemic is still going on, and I've witnessed since being here that Australia seems to be much more focused on infection prevention. Many more people are wearing masks than in the UK, which is pleasant to see. That's fantastic. But I think it's important that whilst these data were collected between April and August 2020, they still are so relevant nowadays, and they will be good evidence and records to keep to really adapt things in the future. So what now? We have different formats of care delivery. At least for us, a lot of the care is delivered more in a hybrid nature. But again, that can cause inequalities for some, and many people we speak to also say we would love to have face-to-face services. So they're becoming much more the norm again. We have a cost of living crisis, so that will impact on how people access care and how much care they access. So likely people will naturally prefer buying groceries as opposed to paying for going to a support group, which, however, is really important as well. And in our country, we have continued social care budget issues. So it's kind of split between healthcare system and social care system, although it should really be well integrated. But unfortunately, the social care system, which supports all those people that are in need, is notoriously underfunded. So having this evidence from the pandemic showing how important social care is for dementia and their carers, there needs to be an overhaul of the system, which is hopefully what this and other research will contribute to make a noise and make a wave. So this was our UK research specifically looking at what's happening since the pandemic. A few months prior to the pandemic, we started a project together with Maastricht University in the Netherlands. And we wanted to just understand what are the inequalities in accessing care and understand, is there some good practice learning we can generate from the Netherlands for the UK or vice versa? Or is it all the same? Now, we started with the survey and the interviews in January, and then the pandemic happened. So unfortunately, we had to stop recruitment and just kind of refocus and rechannel our work. For the survey across both countries, we collected survey data of 103 carers of people with dementia, and we collected, sadly, only 13 interviews from both countries. However, we used this as a pilot study, and hopefully more work will come from this. But we generated one key finding, which I'll go into in a minute as well. So let's talk about that survey. The survey was co-produced with a number of different care providers, so social workers, clinical psychologists, psychiatrists, social care providers. And we also had we had 2 unpaid carers and 1 person living with Lewy body dementia as a key academic member. Unfortunately, one of the carers passed away, so it was quite sad as part of our team. But just to kind of put this into context, this survey was really co-produced. It wasn't just us academics putting something together. This list of post-diagnostic support services was then generated with those care providers and the care recipients. And again, we asked about socioeconomic background, etc. We asked about those support service access, and we asked established measures in terms of well-being, quality of life, carer burden. We asked about everyday functioning as well, so how people perform everyday tasks, etc. But really for this talk, I'm only going to focus on the noted barriers to accessing care. I'm not going to talk much about the everyday functioning measures, for example. So what did we found? So you can see here on the left side, figure 2, that social support service usage. And again, we only collected this data once. Unlike the previous survey where we had 3 time points, this was only done once. And we can see here over 50% of people were accessing support groups for the person with dementia. Also, quite a few people have accessed equipment. So that could be home adaptations, or something to get up the stairs, for example, a handrail, something to the shower, etc. These things. We have daycare center usage, paid carers come in. So quite a good spread. And then to start looking at how things are funded, which is what we're really interested in, we asked people, well, did you fund this yourself or partially, or was it supported by your local authority? And just before I go into that, we noticed that because we asked people about their income levels and general, like, well, wealth or income, more than 50% did not complete that question. They felt uncomfortable, although the survey was anonymized. So we couldn't generate any data in terms of financial background really for this survey. However, people completed this question when we asked them. And you can see here, for example, 63% or nearly 64% were financing respite care themselves, fully or partially. More than the majority financed paid carers themselves, fully or partially. And again, now home meals is not that common, but many people paid for it themselves. So you can see here how things are funded, and it just paints the picture that people really have to have their own funds to access care in the UK, which is very negative. So looking at the qualitative findings as well, we found a number of different barriers that people were experiencing in the UK and in the Netherlands, similar barriers across both countries. So insecure service funding, for example, we also found in both countries that people were receiving way too much information at the beginning of the diagnosis. As I was saying, for the UK, people are often left after the diagnosis, not receiving any support. But what they do seem to get is a lot of information, a lot of packaged details, texts to read, but it's not right. People are already emotionally overburdened at that time. So what should happen is really bite-sized chunks of information throughout the post-diagnostic pathway. Services, again, we found in both countries, services were unsuitable, again, down to age, gender, ethnicity, or the subtype of dementia, or where they lived, might have been too far away. They didn't have the funds to access transport, etc. And two key barriers we found were health literacy and the need to be proactive. So here's just a couple of quotes to illustrate both of those barriers. For example, one person with dementia was saying, I just don't know what's available, you see, no one's ever told me. And this is recurring in all of our research, is sadly not unique. And here, again, something that really shouldn't happen, there should be availability of services everywhere. So this male carer from the UK, he said he searched around for alternatives, looked at City 1, City 2, and then he found something in City 3. Now, we know the UK is quite heavily populated, lots of cities, but really that shouldn't happen. One thing we did find, though, and this is something we're now basing some of our research strategy on and research focus on, we did find one key facilitator, and that's dementia care navigators. Now, I'd be really interested to hear from you and from Chrissy and Rebecca about whether dementia care navigators or similar roles exist in Australia. What we found is they do exist in England. However, they're not evidenced. They're not reported on properly. You can only find out about them via talks to some professionals who might know someone. So they're very much under the surface and not well recognized. In the Netherlands, however, they seem to be very common. And a key facilitator, so the people that we spoke to in the Netherlands, they said, oh yeah, that they're really helpful. They help us navigate the system. And when we talk about care navigators, we mean someone that's not medically qualified, that has a background, say, in psychology or social work, etc., but not a medical professional who can help people with continued communication, say every 6 months or so, navigate the system, navigate them to the services or, for example, the legalities of accessing finances for dementia. So what's next? And I must say, we were pleased to find at least one facilitator amidst the large lake, effectively, of barriers. There are too many barriers out there. So since then, we have completed a systematic review into dementia care navigator models globally. Unfortunately, we only found US published evidence for the time period we looked at. We are also currently finalizing a systematic review into health inequalities and social care in dementia. Again, that's globally. And you can see here, we always register our systematic review protocols on something called Prospero. So you can read up on the protocols already if you're interested. And we're really trying to pursue different funding avenues to explore that key facilitator of the care navigators in the UK and hopefully then expanding to other countries. But one thing that also features, and maybe that wasn't really brought out that much in this talk, which focused more on inequalities, is the focus on the long-term mental health impact of the care workforce and the unpaid carers. So there's been huge inequalities for them because carers have been completely neglected in the UK, at least. And we know from other research in other countries as well. So we want to try and find ways to support the long-term mental health of carers. Another thing, and I've only got 2 more slides left, and then I'll hand over to my other colleague and presenter, just to make you aware, because this is just launched last month. So together with Dr. Kerry Hanna from University of Liverpool, I have set up a new task force for Interdem. I'm not sure whether you're that familiar with Interdem. It's a European network of researchers, but also people with dementia and unpaid carers. And the aim is really to connect and to have specific task forces to focus on specific topics, because really we can learn best by working together across countries and working together globally to understand what works and what doesn't. So you can see here on the right different task forces that are available. And at the bottom one, we've just set up and launched our Inequalities and Dementia Care Task Force. So hopefully there'll be a lot of understanding generated on the system on community level barriers that I was referring to on one of the first slides. And also just to mention, this year, the Alzheimer's Society of England has released a report, which basically summarizes again the findings that we got and that lots of other people have shown, is that people are left to cope alone after diagnosis. There's so many barriers to access. It's just too many unmet support needs. And interestingly, ADI, Alzheimer's Disease International, has launched a similar report this year, also looking at the inequalities after diagnosis. Because, well, why do we need to look at this? We don't want people to be left alone at home and not receiving the care that they should get by not going out, meeting people, getting to the support groups, having their carers supported, etc. We want them to access the type of support they want and need. Not everyone might want to go to a group. They might want to do some one-on-one support, but everyone needs to be able to access this regardless of their background and regardless of the pandemic happening. So one key thing we found as well was that even though face-to-face restrictions have been in place, retrospectively speaking to our carers and people with dementia, people want as much face-to-face support as possible within safe measures. The remote contact is just not the same. So I just want to thank everyone. There's too many people to mention here by name. It's been a fantastic team effort, and just to kind of highlight Maastricht University as well. But yes, thank you very much. Again, put your questions in the Q&A. If you have them, we'll pick them up afterwards. And now I believe I am supposed to hand over to my colleague, Professor Mark Gabby from University of Liverpool, if that's right. I'm going to stop sharing now as well. So it's you, Mark.
To get my camera on and see if I can share. So welcome everybody. Just start this up. if I can, slideshow from beginning. So hopefully you can see that now. Hello, I'm Mark Gabay. This was me before I got my lockdown beard. I'm going to talk to you about the applied research collaborations and what they are and how they work. So they were established in October 2019, and they evolved from something called CLARCs, which were Collaborators for Leadership in Applied Health Research and Care, which, as you can see, is a bit of a mouthful and took me quite some time to learn. And we also have something in the UK called Biomedical Research Centres, BRCs. So those of us who are in charge of the CLARCs preferred to be called ARCs because we think applied research is just as, if not more important. So we've now been extended to spring 2026 for the current applied research collaborations, and these are funded by the UK, well, the English NHS and Social Care Department's R&D scheme called National Institute for Health Research and Care, NIHR, Healthcare Research rather. So we have 175 million split between 15 of us, and we also have co-funding from our member organisations, and there's a certain amount of money put aside for some implementation priorities that we run between us. So we're a collaboration. We bring together, I've just realised I can't see my slides because I've only, oh, there we go, we got across. So we bring together health and social care providers, NHS commissioners, local government, universities, what we call public advisors, which may be patients, they may be members of the public, communities, there may be carers, as Clarissa's just been talking about, and something called the Innovation Agency, which is, again, a regional thing which helps implement research at what they call pace and scale. We've also got voluntary organisations and charities, the third sector, who provide care sometimes or support people with conditions or their carers. And our role is to support the development and delivery and implementation of research into practice, as you can see here. We have a bit of a north-south divide as opposed to a south-north global divide in the UK about health inequalities. And I just use the cliche elephant in the room about that. And so we all agreed that health inequalities had to be our overarching focus. So get this to carry on working. So what do we have? Apologies, I have to keep moving around my picture of who's who. We've got 5 universities, all the specialist trusts in our region, all the mental health trusts, most of the acute trusts, that's the hospitals, 10 local government authorities, a number of charities, 5 primary care networks, which are collections of general practitioners and practices, clinical commissioning groups who used to sort of commission all of the work that was going on in the NHS. They've now been absorbed into something called intermediate care systems, 3 community trusts who provide the sort of district nurses, health visitors, etc., and various other health-related infrastructures. So this is a map, as you can see in pink, of where we are, sort of a distribution. Quite a large area, not of course compared to Australia, but in the English context, it's quite a large area, and we're spread across this sort of 3.5 to 4 million population. There are 15 ARCs altogether, and we link into that and the other NIHR infrastructures which support grant development, delivering studies. There are other schools, School of Primary Care Research, School of Public Health Research, and we all try and interlink and work as much as we can collaboratively. We're going to talk about pipelines and processes that we have for how people can submit ideas to us. As I've said, we have over 60 member organisations signed up to the ARC, and the 3 universities of the 5 act as coordinating hubs. That's Liverpool, Lancaster, and University of Central Lancashire, based out of Preston. We have over 80 public advisors in our Public Advisor Forum, and we have various resources that we developed in what was called the CLARC beforehand. I'm aware of time, so I'll keep moving. So when I say we, who do I mean? As you can see here, I've been very keen to stress from CLARC onwards that the CLARC and the ARC is a member organisation. It's not about the universities doing things for everybody else. We're a partnership, we work together. So we means all of us, it means those organisations and their workforce. And as I say, we're a collaboration. These are some pictures of meetings that we held. The top meeting is where we looked at what the clerk had done, and we got some visual minutes done. And then the bottom picture was us collaboratively coming together in 2018 to decide what we should be putting in our bid for the ARC. Oops, which that's gone very quickly. We'll go back one, sorry. And that's the sort of picture of what we came up with. The words engage, implementation, research, collaboration, resilience. Those are the sorts of words that come up in our minutes about what we're trying to do. So I talked about the elephant in the room, health inequalities. Red is bad, green is good. And this clearly shows the north-south divide. And we are in the northwest, and we have most of the northwest apart from Greater Manchester and the very north bit of the rural part of what's called Cumbria, which lives in the northeast because that's where their patient flows go towards. And as you can see, we are worse than the English average for almost everything. So, as you can see, this is to use another cliche, this is a wicked problem. And it's not something that any single organization can really do on its own. We know from most research doesn't really talk about the differential impact of interventions that are being studied on different groups within society and how its impacts on health inequalities. And we have sought to try and change the way of working to always think about inequalities and equity and how we can put that into our research and implementation and describe the differential impacts, differential problems across those populations. So, as you can see here, it's about how we have a common understanding, how we can work systematically to address these inequalities and think about them differently, to think about how we can utilize our different skills and knowledge sets and links as a cross-system approach, and to act as a resource. So we didn't want to reinvent wheels. So, as I keep saying in this talk, the ARC is a collaboration. And our job is to develop a portfolio of high quality applied research towards the end of the translation, as it's called. So from the science through to delivery to populations, to people in different health and social care settings. And that's the end that we particularly work at, what's called applied research. And then the implementation of that research, so putting it into practice and then understanding the process of putting that into practice, so we can then send it on to the innovation agency and said, so we've tried in a couple of settings, implementing this, putting this research into practice. This is what we've learned about how that process works. So we want to embed inequalities. We want to develop our members and our local communities. So it's all about capacity building. That's a key underpinning. We don't send the research off to academics to do. It's all about putting that research into the community, which is both the populations in those people living in our communities around our region, but also the workforce communities, the communities of practice, and helping them become more skilled and knowledgeable about research, evaluation, implementation. And as I say, there are 15 ARCs, and we also work collaboratively in bigger projects across different ARCs. So we like to give them, we put the public, our public advisors, at the center of our work. And these are some examples of the sorts of things that our public advisors get involved in. And I'm sure these slides are being shared, so you'll be able to see this. And we talk about public involvement, not public engagement, because we see that the role is that our public advisors and the communities that we work with, they are at the core of the work we do, to identifying what the challenge might be, what a solution might look like, how we might develop a research project to look at this, how we'll collect the data, interpret the data, analyze the data, right through to writing up the papers at the end. And if you ever look through Clarissa's publications, you'll see that they all have public advisors as co-authors. This is the way that we work. I haven't got time to show you, but hopefully you can look at this later. This slide links you in to one of our public advisors talking about how the clerk is for her. So bigger happy keyboard here. This is the illustration I did at the time we were putting the bid together of how we have constructed the concept of our ARC to cross this divide of health inequalities. In red, you'll see the research themes: improving population health, person-centered complex care, equitable place-based health and care. We talk a lot in the UK about place-based health, place-based care, but not so much about equity. So this theme tries to look at how we can do that more equitably. The theme that I lead, health and care across the life course. We didn't separate out mental health and physical health. We see them part of the same continuum. And so we always try and look at that. We're sort of, our foundations are around co-production and knowledge mobilization. That's the capacity building. That's the involving all the different parts of the ARC together. And we move from research through implementation to impact. And we have two cross-cutting themes. MIDAS is the methodology theme, and CHI is the care and health informatics theme and how to use big data. That was my approach. The comms lead did this slide, and he preferred illustrating it this way. And again, this lists themes, but it's about this circle of research through implementation back to research, all embedding in capacity building and leading to impact. It's a complex organization, and this slide tries to illustrate how it all interlinks from our overarching vision through themes to development and delivery, and our cross-cutting themes to support that. Originally, health and care across the life course was a cross-cutting theme, but it was so popular, we moved it into being a research theme, but that would have spoiled the picture. How do we offer support? Well, as I've said, public involvement is how we describe experts by experience. That's at the core of what we do. We broker relationships between academics, professionals, and members of the public. We put together training opportunities. We've got 29 PhD studentships, for example. Members in our organizations, our providers and commissioners, etc., they can have internships that we 50-50 fund with their employer to take a day a week out of their work for a year to work on a project and get trained in that process and mentored and meet others. We've got various toolkits and resources that we have, particularly one in health inequalities, and we link externally, as I've said, to different infrastructures, different agencies, as well as across the ARCs. So how do we support ideas to improve health and care? So we have this approach where you can join this at any stage where people submit their idea. We link them into a theme. We help build that project up into an outline proposal. We do our health inequalities assessment toolkit, which I'll talk about briefly, and then we will take it out to our methods team to look at how they can support that and work on it. And I can see somebody's come on screen, which probably means I need to finish because you want to do questions. So we've developed this health inequalities toolkit. Please do click on that website, forequity.uk. It's a really excellent toolkit that helps researchers engage with the public when they're writing and putting together their bids with the public and with other people, and to embed inequalities into it. I'll go through that slide. So what have we done? We've got nearly 200 projects, over 200 publications. These sort of what we've done, we've leveraged nearly £70 million of external grants over the last 2.5 years. Nationally, you can see there's across all the ARCs, lots and lots of work going on. We're all tending to use similar approaches. It's complex and challenging. It's ambitious, it's reaching out, and it's collaborative. And I will stop there.
Thanks, Mark and Clarissa, for those presentations. It's certainly really interesting to hear about the UK applied research collaborations, and also your work, Clarissa, with the dementia care inequalities. Just a reminder for any questions to go into the Q&A. And I have one here, I think it's for you, Clarissa. And the question is the limiting factor the digital maturity of the consumers or of the services providing services digitally without designing them for relevant consumers?
Good question. I think it's both. We wouldn't necessarily use the word consumers, but that's maybe an Australian term, but yes. So definitely, we've noticed though that since the pandemic, older adults have become much more, at least in the UK, much more adapted to using technologies. I mean, my own gran has become much more attuned to using FaceTime, for example, to engage with her family that's not in her own home. So there's definitely the digital literacy issue. But if we think about people with cognitive deficits, that doesn't just have to be dementia. It's really difficult of learning a new skill with that cognitive impairment already. So what needs to happen is there needs to be much more of a digital training provided when people are younger, maybe in midlife, for example. However, the other thing is that services aren't necessarily adapted and designed with people with dementia and their caregivers. So there needs to be more support happening with that as well.
Okay, thanks. Sorry, I was just having a look at the Q&A, and the comment was that they get in trouble for calling people patients. So that's why.
Oh yeah, we can't
kind
call
of
them
use the
patients. We
consumer.
call them usually service users, that or people with lived experiences. So no, we don't say patients either. Yes.
And I think in Australia we had a similar experience with decrease in access to services for people living with dementia and things like that. And just in relation to one of your queries, we do have, it looks like in Western Sydney, it potentially is a trial of a dementia care navigator, and it's being funded by Dementia Australia. And it has a particular focus on people from culturally and linguistically diverse backgrounds living in Western Sydney. It's an ongoing service that's offered free, and looks like it's focused on putting people from CALD backgrounds in touch with government services that they can access.
Oh, that's good to hear. Good to know.
So I've just got another query come in. Well, it's kind of all along the lines of consumer. The term consumer is highly contested here, but there is reluctance to change the terminology among the powers. And another question, are there co-design activities in place to support development of digital solutions?
I'm sure they are, but we in our research don't get involved at the moment. We're trying to secure funding to understand better and improve access remotely to health and social care where that's required. Obviously, we know from our research that face-to-face services should be provided wherever possible, but there's also an element of benefit of having some services digitally. So we're trying to secure some funding, building on our work of how health and social care services could be accessed better digitally and how people could be supported better in doing so. And the workforce as well, because we've noticed that the care workforce isn't always trained up to doing this in the best way possible as well.
Okay, and I might just have, there's one last question. I'm just wondering if you could tell us about some of the challenges of co-designing with people with dementia or cognitive impairment.
I must say overall, it's probably my most favorite aspect of the job, doing co-production and public involvement, and I don't think I'll ever give that up. I love it too much, and it enables me as well to really be embedded and hear about what does it matter, what needs to happen, etc. In terms of difficulties, I mean, I was saying earlier, one of our caregivers sadly passed away during one of our projects, and the person who has Lewy body dementia on that Dutch project and UK project, he has deteriorated so much that he had to step away from the project as well. So he's really struggling at the moment. So I suppose it's the longevity of people living with dementia. If they're continuing to be able to participate, we try and support them as best as we can. But what we also do, what we've learned to do, is that when we have new, what we call public advisors, so carers, people with dementia come in to help us and be team members, we buddy them up with someone who's been involved for quite some time. And then they learn, not learn, but I suppose they start feeling more comfortable and confident quicker to show them we want to hear from you as much as we want to hear from an academic sitting at the table. Your voice is just as important. So yeah, the buddy system helps.
Okay. And sorry, Mark, did you want to?
I was just trying to respond to the next question. I was trying to type it, but then that didn't work. So, and I think let me just get back to my Zoom. Sorry. Yeah. So, how do we recruit? Well, we recruit through all sorts of ways, through third sector organisations. Clarissa has her forum, which you may want to briefly talk about. Word of mouth. Through other organisations. We're also working with all of the organisations in the ARC to help them recruit people into their organisation to support public involvement in their research development and their implementation programmes. And we can offer them guidance and mentorship. So it's a variety of ways. There are various, and I'm going to use the word because that's what's used in health and social care, often by the organisations. They have patient groups. They'll have charities that link to them, so they use those routes to start recruitment for people to help them develop their research. And we would back onto that.
Okay. Now, I just noticed we're just a little over time, so I just want to thank Clarissa and Mark for coming in and speaking to us today. And just a reminder that anyone who's here at Macquarie University, Clarissa and Mark will be hanging around at the Australian Institute of Health Innovation for a little while if you want to come and say hello and have a chat. And apart from that, thank you everyone for participating today. And the presentations will be up on the NIHR YouTube channel shortly.
Thank you very much.
Again.
Thank you
Thank you very much for inviting us. It's been great. Thank you.